Welcome to the first session of Summit. We're very happy to have you here. This should be a great session. We have some really fabulous speakers who are going to give an overview of pulmonary fibrosis. For many of you, this is the first summit you've been to. You might not have been to a lot of educational events before, so this is going to give you a really nice base level of information. But I know every time that I hear a talk like this, I learn something new. So we have been to other sessions like this before. I'm sure that you'll learn something as well. So thank you for coming, and thank you to all the presenters also for being here. I'm going to introduce the first two presenters. We'll go for about an hour, hour and a half, probably closer to an hour, and then we'll have a break. And then we will have two more presenters after that. And then at the end, we're going to have a good half hour for questions. We'll have all the speakers come back up, and you can ask all of your questions of the speakers at that time. Please do hold your questions till the end. It's going to get sort of disruptive. We try to do questions in the middle and that sort of thing in a group this size. So if you can try to remember your question, maybe jot it down. We'll have plenty of time for questions at the end for all of the speakers. So our first speaker is Dr. Joyce Lee. Dr. Joyce Lee is an associate professor of medicine at the University of Colorado. She did her initial training at Northwestern University, followed by pulmonary and ILD fellowship at the University of California, San Francisco, UCSF. She's currently the director of the ILD program at the University of Colorado. And after Dr. Lee speaks, we will have Wendy Mason. Wendy is the program director of the idiopathic pulmonary program at Vanderbilt, and she holds a faculty appointment as an assistant in medicine through the Department of Medicine. Wendy began her work with IPF patients in 2001 as a research coordinator, and she is currently on the board of the Pulmonary Fibrosis Foundation. So please welcome Dr. Lee.
Good afternoon. Is it this one? Yeah. Good afternoon, everyone. My name is Joyce Lee, as Kate mentioned, and I'd like to thank the Pulmonary Fibrosis Foundation for the invitation to speak today. It's an honor to be here with you, and I'd also like to thank all of you, the patients and the caregivers, for coming to a meeting like this one to learn more about the disease that either you live with or are supporting someone who lives with this disease. And it's incredibly important to have knowledge about this disease. It's not a disease that everybody knows, people you talk to, pulmonary fibrosis, what is that? And so the purpose of this particular talk is really to talk about pulmonary fibrosis, what it is, why we care about it, and talk about some tests and things that might be done in your physician's office. Here are my disclosures. So the reason why pulmonary fibrosis tends to be a very confusing area is we use a lot of words in this particular disease state. Interstitial pneumonia, diffuse parenchymal lung disease, and not all of these terms make a ton of intuitive sense. And so what we're going to try and do in the next half hour or so is to really deconstruct some of these terms so that you can explain to others and you can understand for yourself what this disease means. And so here's an overview of the next 30 minutes. What is pulmonary fibrosis? Why do we care about it? Why are we all here in San Antonio learning about this condition? We're going to touch briefly on causes and classification of pulmonary fibrosis, and then we'll touch on testing and monitoring. So what is pulmonary fibrosis? So pulmonary fibrosis is often used interchangeably with other terms, in particular that of interstitial lung disease and diffuse parenchymal lung disease. And for the purpose of pretty much this conference and the rest of this talk, we're really going to be referring to it as pulmonary fibrosis. And while they are used interchangeably, there are some nuances to these different terms, but we're really going to focus on pulmonary fibrosis. And pulmonary fibrosis is essentially an umbrella category term. It is not a diagnosis, but it lumps together a group of diseases that are all put under this umbrella category because they have unifying features of inflammation and fibrosis of the lung. Okay, so it's not a disease, but it's an umbrella term that encompasses several conditions. So terminology. So pulmonary means referring to the lung. And fibrosis means thickening and scarring. And so when we say pulmonary fibrosis, we mean thickening and scarring of the lung. So in order to understand how that thickening and scarring of the lung affects how you breathe, we're going to start with some lung anatomy. So what you can see here is the cartoon on the left, the right lung, the left lung, the trachea, which is the windpipe. And I often educate my patients that the lungs are essentially like an upside-down tree. So you have the main tree trunk, all the little branches that go off and keep getting smaller and smaller until you hit the leaves, okay? And the leaves, in this particular circumstance, we refer to as alveoli. So let me see if I can figure out oh, there we go. So you have your main tree trunk here, the trachea, all the little branches that go off and get smaller and smaller and smaller until you get down here to the alveolus, which is essentially like the leaf of a tree. And if we look closely at this alveolar unit, you can see that they're little grape sacs, essentially. And on these little grape sacs is a very delicate blood vessel network called the capillary system. And this is where we're going to do a little bit of a deep dive. So this is the normal condition. What you have here is this alveolus, this little grape sac. It's a very thin, delicate structure. It's only one cell width. And on top of this delicate alveolar structure is this capillary network, okay, blood vessel network. And what happens is all the blood from your body, once it gets used, all the oxygen taken, it returns to your right heart, gets pumped into the lungs, carrying deoxygenated blood, okay? And as the blood travels through this capillary network, the blood flows this way. The carbon dioxide, which is the waste that our body produces, gets transferred back into the alveolus. And then the oxygen from the air that we breathe in gets put back into the capillary system, okay? In disease states like pulmonary fibrosis, what happens is there is deposition of either cells or scar tissue that shouldn't be there. So this prevents the oxygen transfer across this very thin membrane into the blood vessel network, okay? So we're going to look at this a couple different ways just because, not each explanation might provide a little bit of insight. So here we have a lung biopsy specimen of normal lung tissue. And what you can appreciate is that the lung tissue is actually very thin and delicate. You can see a close-up picture of an alveolar structure right here, and then a cartoon schematic of basically showing these little air sacs where air goes into, and the little thin interstitium that is in between that air sac in the alveolus and the capillary blood network on top of it, okay? When patients have pulmonary fibrosis, those thin alveolar septa, you can see an example here, are then subsequently replaced by scar tissue. Okay, so this interstitial space is filled in with scar and sometimes inflammatory cells, depending on the cause. And so there are several consequences of having pulmonary fibrosis in the lungs. The first is that oxygen can't move from the air into the blood. And so here we have a normal subject. Oxygen carried through by breathing in air goes across this thin alveolar membrane and goes into the blood, goes back to the body so that the rest of your body can use oxygen. In cases of fibrosis, the oxygen has a tough time crossing a thickened barrier, and it can't get into the bloodstream as easily as it would if you had a very thin lung. Okay? Another consequence of this is not only transfer of oxygen from the alveolus and into the bloodstream, is you actually can't bring in as much oxygen into your lungs when your lungs are scarred. And so if you have a normal lung, you can think of this kind of like a balloon, and you blow up the balloon, it fills with all this oxygen that comes in from the air that we breathe. But in a fibrotic lung, those lungs are stiff. And so when you take in a big deep breath in, it doesn't expand as easily as you would in a normal situation. And so the amount of oxygen that's actually delivered into the lungs is lower as well. And so of course, this phenomenon in the lungs leads to what patients feel, how they function, and how they survive. And that's the reason why many of us as physicians and researchers are here today, is to really figure out ways how we can impact each of these domains of patients, because we know pulmonary fibrosis affects all of these things. In terms of how patients feel, I know I don't have to tell you all of these symptoms. You guys experience it every day, but I think it's important for us as physicians who care for patients who have these conditions, as scientists who are trying to find better therapies, that we constantly remember the impact of this disease on our patients' lives. And so in terms of feeling, the symptoms of cough, the symptoms of shortness of breath, some patients experience fatigue or depression or anxiety. And of course, all of these things can adversely affect quality of life. In terms of how patients function, limits your ability to exercise. It may limit your ability to participate in hobbies and recreation that you once used to do, your ability to do certain types of work. Some patients experience memory issues that impair their ability to do their work. And then, of course, social interaction, trying to explain what pulmonary fibrosis is to family members who may not understand, having to wear oxygen in public places and the stigma that may be associated with it. And so that social interaction becomes quite problematic. And then, of course, the one that we all worry about is the impact on how patients survive. Prognosis is limited because of this condition. It can lead to, in certain circumstances, what we call acute exacerbations, so symptoms of respiratory deterioration that require hospitalization. And then, of course, some of our patients are so sick that they have to go on to get lung transplantation. And so it's the cumulative effect of all of these things that we are motivated to try and help patients live better with this disease and to find better therapies to treat these groups of diseases. So we'll spend the next 2 slides talking about causes and classification of pulmonary fibrosis. I told you pulmonary fibrosis is an umbrella category term. It encompasses over 100 different conditions, and certainly we're not going to talk about all of those conditions this afternoon, but what we will talk about is kind of how we think about these diseases, how we group them, and how we narrow our thought process to try and figure out what exactly is driving that pulmonary fibrosis in an individual patient. So here's that umbrella category term again, pulmonary fibrosis. We have lumped diseases into 4 main buckets of disease. The first bucket is the known cause, and so this is where we know what's driving the pulmonary fibrosis. The first example on here is autoimmune conditions. So we know conditions like rheumatoid arthritis, scleroderma, mixed connective tissue disease, myositis. We know that because patients have that underlying systemic process, that process can also injure the lungs and lead to pulmonary fibrosis. The second group of conditions in this known cause bucket is environmental. So this is the disease called hypersensitivity pneumonitis. We know that exposures to birds or bird feathers, exposures to certain molds and certain antigens in the environment can lead to inflammation and subsequent scar formation in the lung, and that is the condition we refer to as hypersensitivity pneumonitis. The third category in this known cause is drug toxicity. So we know all medicines come with risks and benefits, and unfortunately, some medicines have the risk of pulmonary toxicity. Classic medications include methotrexate, amiodarone, or nitrofurantoin. So it's important when your physician is trying to figure out what's causing your pulmonary fibrosis that they know the medications that you're currently on and have been on in the past. And then finally, in this known cause is occupational. The most common one that we hear about probably in the media and lay press is coal workers' lung. So we know that those coal miners are exposed to the dust and the silica in the coal mines, and that can lead to injury of the lung and lead to pulmonary fibrosis. But there are other occupational causes of pulmonary fibrosis as well. The second bucket of diseases is referred to as those with unknown cause. And there's 8 conditions in this unknown cause group. The most common and most well-known of all of these, of course, is that of idiopathic pulmonary fibrosis, which I would assume the majority of you have. But that is our most common interstitial lung disease. There are several others in that group that tend to be more rare or require a biopsy to prove, but IPF is definitely the one that we think of in the unknown cause category. The third group is the granulomatous conditions. This really involves sarcoidosis. Sarcoidosis is unique amongst some of these other conditions in which it's a multi-system disease. So IPF and hypersensitivity pneumonitis and occupational, they tend to be lung-limited conditions. Sorry, I probably shouldn't do But sarcoidosis can affect organs outside of the lungs as well. And then finally, the fourth category is our miscellaneous category. They don't fit nicely into our other categories, so they all get lumped into this singular category. But there are important diseases there. There are things like LAM, or lymphangioliomyomatosis, Langerhans cell histiocytosis, and chronic eosinophilic pneumonia. They tend to have a slightly different pathophysiology or etiology than some of these other conditions, and it's really these groups of conditions on the left that we're mostly targeting here at this conference. So when you go to an ILD clinic, ones in which they have expertise in seeing patients with ILD, this is probably the breakup of the patients that they tend to see in their practice. So most of the cases are equally split between that idiopathic category, the exposure-related category, or hypersensitivity pneumonitis, and autoimmune or connective tissue disease-associated lung disease. And then there is a small category, depending on where you go, where 10 to 20% is either unclassifiable or they have another form of pulmonary fibrosis under that umbrella term that I shared with you. Okay, so now we are going to transition to testing and monitoring in pulmonary fibrosis. Now, this is not meant to be comprehensive. There's probably other tests out there and other ways to monitor the disease, but this is kind of the nuts and bolts of what we do when we care for patients who have pulmonary fibrosis. All right, so I've lumped them into four main categories. We'll talk about signs and symptoms. So these are the things that you're going to be going to your doctor's office with. They're going to examine you. They're going to talk to you. That's going to be in that category. We'll talk about lung function and how we use lung function, imaging, and then other. Now, just like anything else, it can be a wide range of symptoms that patients present with. Some patients come because they had a CT scan and incidentally found this pulmonary fibrosis, and they don't have symptoms of cough or shortness of breath. So that's one way sometimes patients present. Other patients present with a chronic cough or a cold that just won't go away. They keep coughing, and everybody else who had the same cold got better, but not them. Shortness of breath, progressive with activity, with exercise, is a common presenting symptom. Some patients actually don't say they're short of breath, but they're just really tired all the time. They have a lot of fatigue. They have a lack of energy. And so these are all questions that they're going to ask you. And then decreased exercise tolerance, kind of along the lines of fatigue and shortness of breath. Their pulmonary symptoms, whether it's from cough or shortness of breath, are limiting their ability to do the things that they were normally able to do. So when you go to your doctor's office, they're going to ask you all of those questions and try and get a sense of how, over what time period things are progressing and how symptomatic you are from the disease. And then they'll also do things in their office to see how much the disease is affecting what we call your physiology. So they're going to check your oxygen saturations while you're resting. They're going to check your oxygen saturations when you walk. They're going to listen to your lungs to see if you have something called crackles on examination, which is a sign of pulmonary fibrosis. It doesn't tell you how the pulmonary fibrosis got there, but the fact that you have crackles suggests pulmonary fibrosis. It's not diagnostic for. We can hear crackles in many different conditions. So it's just another piece of the puzzle that helps put everything together. And crackles, if they haven't explained it to you, is like taking a Velcro and just taking it apart. And then clubbing of the fingers, again, another sign that we look for, not confirmatory, not pathognomonic, but just a sign that we sometimes see in pulmonary fibrosis, which is clubbing of the fingers. So it's a change in the shape of the nail bed, we think as a result of the pulmonary fibrosis. Okay? Then in terms of, after your first visit, you're going to keep going back to your doctor's office. They want to see how you're doing. And so they're going to ask you symptoms about change over time. So is anything changing? Have you developed symptoms? If you are asymptomatic when you first presented, do you have new symptoms of cough or shortness of breath? Or have you noticed any limitation in your activity by breathlessness? If you had those symptoms or are starting to develop those symptoms, what's the pace of it? Is it slowly getting worse over time, or did it get really bad and now you've kind of stabilized? So we really want to understand how you've been living with your disease since your last visit. The cough, is it better, same, or worse? So it's really important to share those things with your provider because it helps them understand how the disease is progressing in their patient. The other thing they might ask you is whether or not you've been hospitalized since your last visit. So we know that some of these conditions can lead to deteriorations called acute exacerbations, and whether or not you've had to seek medical attention for a respiratory deterioration is really helpful. And then, of course, many of our diseases, we prescribe therapy, and there are side effects that come with some of those therapies, and they're going to ask you how you're tolerating your medications. Do you have side effects, nausea, vomiting, diarrhea? How's your appetite? Have you lost any weight? These are all important things to share with your physician. In terms of the things that they'll measure at that doctor's visit, of course, your weight. Some patients lose weight, either related to side effects of therapy or related to the disease itself, and so that's something we'd keep an eye on. Of course, change in oxygen needs, and so if you're telling your doc, I feel more shorter breath than I did last time, they're probably going to retest those oxygen needs and see if that's because you need oxygen. And so they'll keep assessing the oxygen needs. And then finally, the one other thing that we start to look for as patients progress on their journey with pulmonary fibrosis is signs of stress on the heart. So when patients have lung disease, the heart can sometimes have a hard time pumping through a fibrotic and stiff lung, and that can lead to stress on that heart and lead to something called pulmonary hypertension. And sometimes we can pick up clues on that on the physical examination to determine if you're starting to develop signs of pulmonary hypertension. So now we're going to move on to lung function. Lung function is not used to diagnose patients with pulmonary fibrosis, but there are clues when you look at lung function that can suggest that there might be pulmonary fibrosis occurring. So in patients who do have pulmonary fibrosis, that awesome maneuver in the pulmonary okay? And the things that we measure in pulmonary fibrosis, two measures out of that whole pulmonary function test. One is called the forced vital capacity. That's how much air you blow out of your lungs, okay? That is the primary measure that we follow. And then, of course, our gas transfer value. I showed you that when you have pulmonary fibrosis, it impairs the oxygen transfer from the air into the bloodstream. And we measure that using the diffusing capacity for carbon monoxide, or the DLCO. Okay, so two main measures that we look to see the severity of the pulmonary fibrosis at baseline, and then we follow these metrics over time. So then in terms of monitoring of lung function, we regularly monitor both of these metrics. We get them every 3 to 4 months, and it gives us a little bit of a snapshot into how the lungs are doing and whether or not they're staying stable, whether or not they're getting worse, or whether or not they're getting better. And of course, there can be some noise in these measurements, and so we really look at trends over time. So not making decisions on one low value or one high value, but really it's trends over time that tell us as your physician how your lungs are doing. Now we're going to move on to imaging. Now, unlike lung function, imaging's home is really in the diagnosis of pulmonary fibrosis. And so I'm sure all of you have heard and have had, as a patient, a high-resolution CT scan of your lung. And this has really become a key diagnostic tool in the pulmonary fibrosis. And so what CT scans do is to take very thin slices of your lung, kind of like you would cut a bread loaf, okay? And the high-resolution CT scan takes even thinner cuts than normal CT scans would do for example, like lung cancer screening. And so it gives us a good picture of all the lung tissue from the top of your lungs all the way down to the bottom. And when we look at the CT scan, air is reflected as a dark color or almost black here. And then tissue, like for example, your heart here shows up as gray or white, okay? And along with your clinical history, your occupational history, your exposure history, all of these things, with the CT scan, many doctors can figure out your diagnosis in about 50% of cases with all of this information, okay? These patterns are important. So what I've shown here is a CT scan of someone who has normal lung tissue. You can see all the black because there's so much air in the lungs. Little white dots and little white lines are blood vessels, but this is how a normal lung looks. When somebody has pulmonary fibrosis, you can see, starting at the edges here, that there are these irregular, coarse, white lines. There's this area of honeycombing right here. And then you can see this kind of haziness on top to suggest ground glass. And so this is the difference between a normal lung CT scan and one that has pulmonary fibrosis. So in terms of monitoring, we actually don't routinely get CT scans to monitor disease progression. We do worry about the cumulative radiation exposure over time. So it's really critical at the time of diagnosis that you get the right CT scan and that we really closely examine the lungs with the CT scan. But in terms of following over time, we don't routinely get it like every 6 months or every 12 months. It really depends on the clinical scenario. And some patients will get it, after a year on treatment, you might want to see how the lungs are doing, and a year later seems reasonable for most physicians. But other times you might actually get it is you go to your doctor and you say, hey, for the last 30 days or a month or a couple weeks, I've been feeling more short of breath. And they can't figure out what's going on. Then they might get a CT scan of the lungs to determine whether or not there is a pneumonia there or other process that could explain your worsening shortness of breath. So it's really used if they're trying to figure out what could be happening that's separate from the diagnosis, okay? And then, of course, if you have other indications for chest imaging, like lung cancer screening, that might be another time where you're getting more regular CT scans of your lungs. But we don't routinely recommend regular interval CT scans like pulmonary function tests. Okay, so that's imaging. We're going to end with these other tests. And this one was a bit more challenging because everybody practices a little bit differently. So I'll show you the things that we sometimes use in the diagnosis of interstitial lung disease. So oftentimes you're going to get some blood tests for the diagnosis of what's causing your pulmonary fibrosis. This may include autoimmune blood tests to look for underlying rheumatoid arthritis or scleroderma if you didn't already have that diagnosis and you have some hints on the physical exam or your symptoms that your doctor's like, I wonder if scleroderma could be contributing. They're going to send off some blood tests to look for that. Sometimes some of these conditions can be hereditary in family members called familial pulmonary fibrosis, and in certain circumstances, genetic testing may be done to better understand the genetic risk factor for the pulmonary fibrosis. Bronchoscopy is sometimes done in patients. Mostly in our practice, it's to exclude infection. So for example, if you have someone who has rheumatoid arthritis and they've been on immune suppression because they needed it for their joint control, and the CT scan is not convincing for fibrosis and you wonder if infection could be leading to those radiologic abnormalities, then you might go on to pursue a bronchoscopy. It's certainly not universal and it really is patient dependent. And then some patients actually require a lung biopsy to go on to figure out what is causing their pulmonary fibrosis. It's not for everybody. You have to take into account the risks and benefits of undergoing a surgical procedure and that the benefits outweigh the risks. And so that's a very close discussion with your pulmonologist to figure out whether or not there's any benefit to moving on to a surgical lung biopsy. But we do use that in certain cases. And then in terms of monitoring, blood tests are probably going to be taken to monitor the effects mostly of medicine. So a lot of the medicines that we use, whether it's antifibrotics for idiopathic pulmonary fibrosis or immune suppressants for autoimmune-related interstitial lung disease, we will want to make sure that those medicines aren't harming the rest of your body because they have known side effects and that they're helping the lungs. So liver function testing, white blood cell count, and complete blood counts could be obtained in follow-up. And so really, I just want to end with these conditions are a challenge. And it's a challenge for patients, it's a challenge for your providers, but it really helps when we have a multidisciplinary approach to this. And this is something my mentor many, many years ago emphasized to me, that the approach to the diagnosis and management of interstitial lung disease truly takes a village. I mean, we have expertise from pulmonary, rheumatology, radiology, pathology, surgeons who may need to do a lung biopsy or get you a lung transplant. We have to take into account a whole ton of data, clinical, physiologic, radiologic, other testing to help us come up with the right diagnosis and the right treatment management plan. And then we have to partner with our nurses, our pharmacists, our social workers, rehab specialists, and other teams to really provide a multidimensional and multidisciplinary approach to care. So hopefully you're going to meet a lot of these people here today at the conference and the next few days, and to learn more about your disease. And thank you for your attention.